Artificial intelligence is rapidly integrating into every corner of modern healthcare. Algorithms currently generate predictive analytics, analyze complex diagnostic scans, and track patient outcomes at speeds a human clinician cannot match. As machines take on complex cognitive tasks like reasoning and decision-making, a specific assumption is taking root at the bedside. Clinicians are increasingly presented with a digital directive from an electronic health record system. Because the output looks definitive, it creates an illusion of algorithmic authority, the idea that the machine is making the diagnosis and absorbing the liability. If a clinician defers to that machine's authority without questioning its logic, and the machine generates an incorrect care plan, a critical question arises: who is legally responsible for the error? Treating AI as an autonomous decision-maker ignores the legal, ethical, and regulatory reality of nursing practice. The American Nurses Association and the Texas Board of Nursing have established a firm regulatory stance to clarify how algorithms fit into the clinical hierarchy. This document outlines the ANA's position. It officially classifies clinical AI strictly as an adjunct tool. It is designed to augment, support, and streamline expert clinical practice. It is not a replacement for human skills, knowledge, or critical judgment. The mandate is absolute. Systems and technologies assist in clinical practice, but the nurse remains fully accountable for their decisions, even in the event of an AI system or technology failure. In daily practice, the nurse is positioned as the ultimate clinical firewall, standing between a potentially flawed algorithmic output and patient safety. Integrating advanced technology into a hospital does not remove responsibility from the care team. It demands a higher level of ethical scrutiny and clinical vigilance at the bedside. To understand where this vulnerability lies, we must map how clinical AI functions within a hospital setting, moving from abstract rules to concrete workflows. We start with raw patient data. This information is collected from the bedside and fed into the AI's proprietary algorithm. The algorithm processes that data and generates a specific clinical prompt or care directive within the electronic health record system. The primary professional vulnerability occurs right here. It is the moment the care team is tempted to act blindly on the prompt without verifying its clinical accuracy. To mitigate this risk, the workflow requires a hard, unyielding barrier between the EHR prompt and the actual care plan. This is the human intervention gate. At this gate, the clinician must intercept the AI's output. They apply their own independent judgment and physical assessment to validate the machine's hypothesis before delivering care. The workflow clearly maps the reality of the technology. The algorithm is a sophisticated suggestion engine. The actual medical decision occurs entirely within the human intervention gate. This gate exists because the inputs fueling the AI are inherently flawed. We have to examine why an algorithm's suggestion requires clinical skepticism. This excerpt details ethical AI integration, highlighting a core limitation. AI's diagnostic performance is completely dependent upon the population data used to train it. If a model is trained on records containing systemic biases, it carries those exact biases into clinical implementation. For example, if a profiling algorithm is heavily tested on specific demographics, it performs poorly for minority populations. This leads to diagnostic tools that actively generate discriminatory outcomes. This introduces the ethical principle of justice into data science. Justice in this context is the nurse's proactive duty to identify and mitigate algorithmic disparities. A nurse must look at a statistically generalized AI prompt and ask if it is actually safe and valid for the unique, individual patient in front of them.
Data is not neutral. Treating an AI's output as objective truth without examining its underlying demographic bias directly violates the mandate to provide equitable care. The legal and professional framework governing this conflict is clearly outlined in Texas Board of Nursing Rule 217.11. The mandate is explicit. If a nurse believes an AI-prompted treatment regimen is inaccurate, non-efficacious, or contraindicated, they are legally obligated to halt the care plan. The nurse must immediately notify the ordering practitioner and carefully document their decision to override the system. A clinician cannot defer to the machine's authority if the output compromises their assessment of patient safety, regardless of pressure from the hospital system. Failing to intercept a flawed AI prompt carries severe professional and legal risks, linking directly back to the clinician's absolute accountability. The standard is absolute. Executing an algorithm's error without question is professionally indistinguishable from committing the error yourself. This vulnerability extends beyond hospital EHR systems. There is a massive influx of big data generated by consumer health devices and online symptom trackers. Patients frequently input highly sensitive details into these commercial platforms, falsely assuming their information carries HIPAA-level privacy protections. This section outlines data and informatics considerations. The algorithmic models governing consumer applications are protected trade secrets, obscured by legal jargon. Because consent is rarely transparent, vulnerable populations face the severe risk of financial exploitation as private health data is sold. In the digital age, the ethical principle of autonomy dictates that true informed consent is impossible if a patient cannot comprehend exactly how their data is being used. The nurse's role is evolving to meet this challenge. They are tasked as digital health educators, bridging the health literacy gap to help patients protect their personal data. Protecting a patient's autonomy now requires safeguarding their invisible digital footprint just as fiercely as their physical well-being. Returning to the clinical workflow, we can permanently redefine AI's position within modern medicine. The expanded flowchart places the AI black box alongside lab results, vitals, and medical history. Every data point converges on a single central node, the nurse. This hierarchy treats the algorithm as a fallible data stream, requiring the same level of human synthesis as any other diagnostic input. Validating these algorithms places an immense cognitive burden on the individual nurse. While the bedside clinician remains strictly accountable for their specific actions, the broader system requires a second layer of oversight. To address this, the Board of Nursing recommends that healthcare employers establish ethics committees. These bodies govern the integration of AI tools and ensure the transparency that a single clinician cannot provide alone. Systemic technological risks require systemic governance. Protecting the bedside workflow starts with holding institutions and software developers accountable for the tools they deploy. The rapid integration of AI frequently raises an existential fear regarding the automation and diminishing of the human clinician. This summary emphasizes the foundational elements of nursing. Machines process vast data at incredible velocities, but possess zero capacity to advocate for a patient, to empathize, or to practice ethically. Rather than replacing the nurse, the influx of complex data drastically elevates the demand for independent, highly skilled clinical judgment. Artificial intelligence is a tool. The ultimate, irreplaceable authority in healthcare remains the moral and clinical agency of the human nurse.